Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
There you go.
Well, that was smooth. Hello, everyone. This is another guest episode. It's a hard one to say. We are joined this week with Dr. Brendan Robinson. He has an awesome job that I'm going to ask him to tell us about in a second here, but he is an internist at a psychiatric hospital. And Brendan, you've been talking to us about it. I'm wondering if you can just quickly let the listeners know the ins and outs of your job. It's so unique and something I think sounds really valuable and rewarding.
Thanks for having me here today, Mike and Andrew. It's really a great pleasure of mine to be here on the Diagnostic Atypia podcast. I've been a long-term supporter and a long-term fan of you all, and I really think you all are doing great work. Again, my name is Brendan Robinson. I'm an internist, trained in internal medicine, did a chief year, and have worked in hospital medicine since graduating from residency. I have a little bit of a unique role currently in that I work at a state psychiatric hospital as an internal medicine physician. I do a combination of primary care as well as acute medicine here at the psychiatric hospital, which has been a unique practice, but I greatly enjoy working with those who have serious mental illness, and it's been a great pleasure of mine to care for this unique and vulnerable population.
That's so cool. Thanks for being here, Brendan, and letting us take a peek into your life, hopefully through a case from your institution where you're working right now. I did inventory and try and recall my old shelf psych exam sort of questions before the session, but please lead us along and let's see where this case goes.
Today I have an interesting case for you all, which you see he split up into aliquots, as you all are familiar with, and I'll go ahead and start with aliquot 1. Aliquot 1 is a 56-year-old male presenting to the emergency department for cardiac arrest. Over the last 4 to 5 days, the patient developed nausea, vomiting, and diarrhea with fatigue, poor appetite, and he was sleeping more per his spouse. He had no hematemesis, melena, hematochezia. There was no associated abdominal pain. He did not have any fever or chills. His wife states that he was eating poorly with decreased oral intake. There was no chest pain, palpitations, dyspnea, orthopnea, PND, or edema. On the day of admission, he was in the bathroom and was standing in front of the toilet when he collapsed into the tub and lost consciousness. His wife found him with a questionable pulse, called 911, where she was instructed to start CPR. Emergency medical services arrived and within 4 to 5 minutes took over resuscitation with initial pulseless electrical activity as his initial rhythm. ROSC was obtained very quickly with just 1 round of epinephrine and CPR. There was no shocks delivered. He was already following some commands in the emergency department without sedation on board, and that's the end of aliquot 1.
Wow, very interesting. It sounds like the question of cardiac arrest or not is still up in the air, but I would certainly frame this case as acute hypotension in a patient who just collapsed. And anytime I hear someone who stands and then collapses, it raises that idea of like orthostasis. And certainly with the history of very, very high volume fluid losses over the last several days, raises the question, is the patient hypovolemic from all of that? I think in terms of management reasoning for a patient arriving to the hospital like this, they'd be getting liters and liters and liters of fluids right away, just empirically, while we're figuring out what's going on, even before the labs are coming back. And it'll certainly be interesting to see the labs after that resuscitation, though, because it sounds like this patient could be very electrolyte depleted from all the diarrhea and emesis that he had, and certainly critical hypokalemia, critical hypophosphatemia. These sorts of electrolyte derangements can cause malignant arrhythmia, and he could have had a cardiac arrest on top of that. So I'm more like it's just trying to figure out what's going on right now, what was happening the last couple of days. I'm just trying to keep this patient alive right now. And Mike, those are kind of my scattered initial thoughts. What do you think?
Yeah, I mean, the patient comes in post cardiac arrest. If that, I mean, again, I'll get into that in a second, my thoughts there, but whenever I see that in like quotes. But I mean, yeah, this is sort of like ABCs before an H&P kind of thing, right? So just, we need to just make sure that this person continues to be alive. And if someone's orthostatic before this, and now I agree that probably hypotension is the thing that brought them down. And so, sort of exploring the etiologies that would quickly kill them, right? And so once you have pulses back, making sure this person is not having an MI, what is that rhythm that they get when he comes back? That would be a good thing to know. If that's, sometimes you don't have that, but sometimes the ambulance has the strip there of this is what the rhythm was when they did get a pulse back, right? And then I agree with you that, just hearing the history, common things being common, just hypotension itself, although that would be odd for someone this, he's 56. He could have really severe cardiomyopathy we're not aware of, but generally I don't know if someone arrests from just being hypotensive alone. But the electrolyte situation, in terms of like when we have actually a fair number of patients I've seen since I've started that are like a question at cardiac arrest. Like oftentimes it's like an ICU transfer. They come out of the ICU like one day after this cardiac arrest. And, sometimes like really it is such a, particularly like in hospital arrests where it's, a minute or two until ACLS is begun, right? Like you can get like pretty quick recovery, but for me, the tip off is when, there's like really very few lab abnormalities, right? So, I mean, you'd expect even with just some minutes of no cardiac output, you should have a pretty substantial AKI. They should have elevated transaminases. And so, I've seen some patients where none of those things were present. And so again, it's just hard to believe that truly they had no cardiac output. Their blood pressure was zero and they experienced no hypoperfusion in terms of their labs. So that would be the other thing I would be looking for. And so, if those things are actually not as abnormal as we expect, then I wonder did they really, lose a pulse, or was it just that in the heat of the moment, it's hard to feel a pulse, particularly if it's your loved one, right? And was there, in addition to maybe something like orthostasis, something else that brought this person down? And I guess getting a history, like, does he really remember standing up? Or did he have some other sort of neurologic issue that brought him down, like a seizure? Maybe he's really hyponatremic from all the diarrhea loss, and this wasn't actually a cardiac event, but it was a neurologic event. And then in the heat of the moment, they just couldn't feel it. Or maybe he has weak pulses because he's hypotensive. So those are my initial thoughts. I'm interested to hear what the initial labs are, and then, kind of where things go from here.
Aliquot 2 is going to go into a little bit of past medical history for the patient. He has a history of coronary artery disease, status post a very recent 3-vessel CABG 6 days ago. This was an uncomplicated procedure, and he was discharged out of the hospital just about 24 to 36 hours ago after that admission for a CABG. He has also a known diabetes type 2. He has hypertension, hypolipidemia, and nicotine use disorder in remission. Prescriptions are kind of the usual medications you would see in someone who has coronary artery disease. He's on a statin, he's on an aspirin, a beta blocker, as well as an ACE inhibitor. He takes metformin, he takes glipizide and Lantus for his diabetes. In the emergency department, he was hemodynamically unstable, requiring pretty high doses of vasopressor support. He was requiring 30 micrograms of Levophed, as well as 0.04 units of vasopressin to maintain his mean arterial pressure. His EKG in the emergency department showed T-wave inversion in the anterior leads, but no associated ST elevation or ST depressions. Cardiology was called given his recent CABG and known cardiac disease, and they had a plan for emergent left heart catheterization to evaluate his graft patency. He was intubated and at this point sedated and on vasopressor support, and that is the end of Aliquot 2.
Ooh, Mike. I feel like we're in the hot seat right now. I'll let you take this one first. All you.
Well, it sounds like there was hypotension. So, or at least that's part of the issue here. I'm trying to think of how I want to frame this clinical reasoning wise, because I think there's a couple different ways. Um, right, I had mentioned he's 56. We don't know what his heart history is, right? So that totally changes the way we think about him. The fact that he's had a cabbage within a week of this, and so certainly ischemia becomes the number one thing that needs to be ruled out as the cause of his arrhythmia, or as the cause of his arrest, excuse me. And so, he's going to left heart cath. And I just want to clarify, we're still waiting to hear what they find, correct? Okay, perfect. And so what I think I'm hearing is that he sort of has refractory undifferentiated shock. I'm guessing, right? I mean, that's what I'm hearing. He's on 3 pressors and, we're just continuing to add them. And I'm not hearing any localizing, infectious sources, obviously, other than maybe a colitis of some sort, some sort of, because that's the diarrhea is really what preceded this. But, nausea, vomiting, diarrhea are very nonspecific. And usually sort of if you're infected and you've got stuff throughout the GI tract, upper and lower, it's oftentimes something viral. Which doesn't tend to cause shock unless you get really, really dehydrated from it. So, I think that what I'm hearing is that we need to think more broadly about why someone is in shock. And, septic shock usually responds fairly quickly to vasopressors because it's a vasodilatory state. And if the heart's working okay, you're usually able to get people some amount of response, right? And then sometimes it's just too late. Sometimes you don't have source control, and so you're adding more and more pressors. But I find that in general, people coming in with sepsis, there's at least some response to Levophed in general. And so then the question I think next is does this person have cardiogenic shock, which I would say is equally, if probably not more likely, because of just his cardiac history. And we don't know what we're going to find on there, right? Like if the whole LAD is just occluded, or all of his grafts, are occluded, then it very easily could just be in cardiogenic shock. And no matter how much pressors you give him, right, it's not really a problem of vasodilation; it's just a problem of the pump. And so you can give inotropes, but if you don't have any oxygen delivery to the tissue, it doesn't really matter. And the other thing that I just sort of always is in the back of my head when someone has like refractory shock is, does this person have some sort of adrenal insufficiency, right? We need cortisol in order for pressors to work. That's sort of how they work, right? Is through a system that involves cortisol. And so, I guess I would be looking not at the moment because things are extremely critical, but I think I would probably be thinking about, was there anything that happened during the cabbage that, could have resulted in some sort of adrenal injury. I don't know why. Was he markedly hypotensive during the procedure though and infarcted? But I can't imagine that person then goes home a couple days later. And so that's another thought. And then, does he have a PE? Does he have a pneumothorax, sort of obstructive shock as well? Those things are just not going to get better until you treat them, and are also well-described causes of cardiac arrest. And so my guess is that since they took him to left heart cath, I imagine at some point between the door and the cath lab, he probably had some imaging of the chest. And so I'm guessing that at the very least, we're not hearing about a pneumothorax. But those are, I think, my initial thoughts. And, really until we know what the grafts look like, it's going to be hard to say that it's not the heart. Andrew, what are your thoughts?
Yeah, I love those thoughts. I'm also running all of those 4 buckets for hypotension: cardiogenic, obstructive, distributive, hypovolemic. And I was doing the same thing you were doing. Like, how would this patient look after therapies if there was only one etiology, which Brendan already gave us up front, that there's probably more than one thing going on. So I think we could say this patient probably had some degree of hypovolemia from all of the fluid losses, but clearly that's not the answer, because the illness script for pure hypovolemic shock, like if you're getting cholera, I mean, that's a life-threatening disease elsewhere because there isn't crystalloid, but we have crystalloid here in the States. So if someone has cholera, we can resuscitate them and they get better. So it's automatically there's something else going on other than hypovolemia in terms of the hypotension here. And I was thinking the same thing you were thinking too, in terms of what in distributive hypotension is a little bit more refractory than just kind of low dose pressors. The two I had were adrenal insufficiency, as you mentioned, and toxic shock syndrome is a very, very, very aggressive illness, but we don't really get the sense that there was something preceding this, like a limb was hurting or there was a sore throat from a group A strep infection that would have caused this. So I'm not thinking about that so much, but I'm sure this person was started on broad spectrum antibiotics while things shake out. I do wonder, I don't know much about post cabbage complications, but I'm trying to think of what could happen after the cabbage. Anytime I hear about vasopressor requirements going up and up and up, and things almost like spiral out of control through that, I think of LVOT obstruction. I don't know why this patient would develop an acute LVOT obstruction, though, so I'm kind of like crossing that out. The other thing I'm thinking about in terms of high dose pressor requirements acutely is just obstructive hypotension, like PE patients crash very quickly. And I'm thinking, okay, well, this patient could have a PE. So if the left heart cath is negative, we can go down that pathway. But I think more importantly, an echocardiogram, just like a POCUS on this person to look for tamponade would be really important. I don't know if there's some sort of like leak around the graft that could have caused like slow hemorrhage, or rather acute hemorrhage causing acute tamponade. And then beyond that, of course, they're going to the cath lab to assess for occlusive MI. We see, it sounds like what could be reperfusion waves in the anterior T wave inversions. That could just be purely because we just had this patient arrest and we reperfused them and they're okay for now. But it also could mean that maybe their LAD was transiently occluded and it reperfused on its own. So I think this all sounds good. We're going to go to the cath lab, and I'd really love, honestly, a POCUS after this just to make sure that there's no tamponade, I think, next.
Aliquot 3 is going to go through some of his initial workup and initial labs. He had a CBC obtained, which revealed a white count of 16 with an associated normal differential. He had a hemoglobin of 12 with a hematocrit of 35 and platelets of 56. He had a BMP with a sodium of 128, a potassium of 3.0, chloride of 96, a bicarb of 14. He had a BUN of 33 and a creatinine of 1.8 with a baseline of around 0.8. He had a glucose of 70. His AST was 280, ALT 200. Total bilirubin was 1.8 and his albumin was 3.4. He did have high sensitivity troponins checked at an initial 0-hour troponin of 404, which downtrended to 256 at a 1-hour check. He did have a lactic acid obtained, which was 6.8. His coags were normal. His fibrinogen was normal. He had a VBG with a venous pH of 7.24 and a PCO2 of 38. Bedside ultrasound was obtained, which revealed an IVC which was collapsing less than 2 centimeters. There was no distension of the IVC. His left ventricular ejection fraction was grossly acceptable. There was no RV dilation. TAPSE and MAPSEs were normal limits on his echocardiogram as measured. He had no pericardial effusion. He had a CT of the head, which revealed normal gray-white differentiation and no associated bleed or subacute to chronic stroke. He had a chest CTA, which revealed bibasilar infiltrates, no pulmonary embolism, no dissection, and normal postoperative changes from recent cabbage surgery. And that is going to be the end of Aliquot 3.
Very interesting. As I'm listening to all this, I'm kind of categorizing what's complication from the arrest versus what's signal for what happened before all of this. I would guess the bibasilar infiltrates are probably aspiration pneumonitis from this event, but we can always recircle back to that hypothesis. I think that the POCUS is very, very helpful because in obstructive physiology for hypotension, it really necessitates IVC distension, is my understanding. So it has like a very, very high negative predictive value for obstructive physiology. And you also gave us other evidence that there isn't PE driving the physiology in terms of there's no RV blowout or anything like this. But I think that the collapsible IVC, the non-distended one, is very, very helpful. So I think we're thinking less likely it's really obstructive physiology. So I think we've kind of crossed out obstructive so far. I think we've crossed out hypovolemic so far in terms of what's actively driving what's going on for the patient. And then it sounds like, just like with a gross look at how the LV is doing in terms of its contractility, like it's doing okay too. So, barring the heart rate isn't like 10 or the heart rate isn't like 200 and the valves look okay in all of this, then I'm kind of surprised, because I think we're kind of back to distributive hypotension, Mike, unless if I'm missing something here. And I honestly wasn't expecting to end up there, just because this is kind of like cardiac patient, just very high risk for cardiac and obstructive physiology driving the hypotension. But where did your head land with this?
The same, I think, because we've just ruled out so many things with all of this evidence, right? We don't have a good argument towards cardiogenic shock at this point. We've really effectively ruled out PE, right? I mean, even if we've missed something small, it's really not enough. It wouldn't be enough to explain anything right on a CTA. And I agree that the lung infiltrates could be, right, pneumonitis, and absolutely, I mean, that's enough. Pneumonia, right? I mean, that's enough to cause septic shock, or sort of just a vasodilatory shock from just inflammation from pneumonitis. I just saw that yesterday, actually. But I mean, it's a little underwhelming, and it seems like it probably came second, not first. I agree. Yeah, I think also, right, his hemoglobin's pretty benign. I don't think that he's bleeding somewhere. I'm sure he did get a lot of anticoagulation during that procedure, during the surgery, but I'm not seeing any signs of bleed. We're not seeing blood anywhere. He has a white count that could be 1,000 different things, right? And I'd say that his labs look suggestive of a recent cardiac arrest, although not as overwhelming as I'd expect. I mean, the lactate, I think, is the thing that jumps out the most. Yeah, I think we're left with really distributive causes, particularly because we know if he's hypovolemic, right? Because he does have a collapsible IVC, he at least should have been resuscitated very much adequately at this point from that perspective. And so it really leaves that the pressures aren't working because the vasculature is not working. And I guess the other thing I would think of is, did he, we know that the head CT, dry CT, is fine. There's no bleed there, but just like a neurogenic cause, as he went down into the bathtub, did he in some way damage his, I imagine he fell forward, so I don't think he would have, but did he damage his cervical spine in some way that he now has neurogenic or vasodilatory state, or like a neurogenic shock? But yeah, I don't know. Those are my thoughts. I feel like all the labs, I guess the one thing is the platelets are low. But I don't know what to make of that in isolation. I guess one question I'd have is, do we know if this guy has, a baseline cirrhotic, it doesn't sound like it based on his past medical history. I'm not hearing that, but right, he's got like mildly elevated AST, ALT, and a low platelet. But, I think that's all just related to arrest. Could he have hit from heparin that he got during the surgery and his platelets are now low? But I think that we would have seen, I mean, it would have to be, right, like, where would he have a clot else other than the pulmonary artery that would create this degree of shock, unless maybe he clotted both of his adrenals and infarcted them. But yeah, I guess that'd be the other thing that doesn't quite fit, the thrombocytopenia. It would be helpful to know what it was a week ago, if that's a marked change, or if it's sort of recovering or the same. Yeah, I don't know. I'd probably just give him hydrocort because I don't want him to die, and see if there's a response to it. But I think probably at this point I'm going to have to treat for sepsis with something broad, just because he's that sick. I don't know what I'm treating, but I suppose a pulmonary source. I don't know. Those are my thoughts, Andrea, if there's anything else. But I think we just need to honestly hear the next couple hours of his care, what happens. I don't know if steroids were given, but I think they would be reasonable to try, and antibiotics. And maybe I don't know if have we scanned the abdomen. I mean, that'd be another thing just to take a look. He's I think a pan scan guy at this point. So I don't know if that was done. I mean, you may have said that and I missed it.
Yeah.
I'm going to stop blabbing. Stop yapping there.
No, that sounds good, Mike. I feel like, yes, CT torso, look for infectious sources. I love the hydrocort idea. I'd probably put in clindamycin for this toxic shock idea, just because I haven't seen many cases that are so fulminant like this, and we're thinking distributive. I'm open to being wrong, but I think we're just trying to kind of do everything at this point to make sure things don't get worse. But Brendan, what happened next?
Aliquot 4 was the patient went for emergent left heart catheterization and hemodynamic measurements in the cath lab. Left heart cath revealed that his grafts were patent. He had mild residual left circumflex disease. He had a normal left ventriculogram. He required increasing vasoactive support in the cardiac catheterization lab, and phenylephrine was added at 100 micrograms. He also received 2 liters of additional IV fluids given in the cath lab, given his worsening hemodynamics. He underwent a right heart catheterization, was revealed cardiac index was preserved at 3.0. His SVR was low at 400. He had a mild increase in his mean pulmonary arterial pressure at 33. Consistent with mild pulmonary hypertension, and his central venous pressure as measured was 3. He had a C. diff toxin sent, given his recent GI illness and shock-like state. He also had blood culture sent. A urinalysis was obtained, which was within normal limits. He had a tracheal aspirate sent, and that is pending. Given his bibasilar infiltrates, he had a strep pneumoniae and Legionella antigens were sent, and those were negative. He also had a respiratory viral PCR that was checked, and that was also negative. He was started on vancomycin, azithromycin, and Zosyn for presumed septic shock, and that's going to be the end of Aliquot 4.
And he was on 4 pressors, but not on steroids. I just want to clarify. Okay. Andrew, I guess I'll see if you want to go first. If not, I guess I can fall on the sword.
Yeah, sure. I could go first. I'm just like taking a step back and wondering, you were talking about we talk about treatment failures and infection as a source control issue. The idea of giving more resuscitation does raise the idea of crystalloid resuscitation does raise the idea, is there a source control issue for a bleed? Which I'm wondering, is the patient's belly like getting really distended now? I mean, the platelets were 50, they are at a high risk of a bleed. Is there some sort of bleed in the belly that's going on that we're missing? And maybe they actually do need more resuscitation. Not only that, but source control of that. So we surgically fix whatever bleed is going on in the belly. But other than that, Mike, I'm not too sure. Yeah, I'm like you. I'm happy to fall on the sword for you. I think I got to pass it to you now.
Well, I think I'm going to have to fall on top of you onto the sword, and we'll make sort of a sword sandwich here. But yeah, similar thoughts. I guess the issue here is that we don't have a lot of time, right? Like the tincture of time can be helpful sometimes in just understanding the diagnosis because of how someone responds to treatment. But this is sort of the most frightening situation where you just don't have really much time. I'm trying to I'm wondering if I am anchoring on all of those initial labs being the result of cardiac arrest, right? Like, is it possible that he has some sort of infectious etiology that's hitting the liver, and the platelets, and we're missing it. Just trying to make sure that we don't just explain that by ischemic hepatitis. Andrew, you are better at that than I am in terms of, I feel like anytime I think of interesting or rare infections that hit the liver, I think Legionella is one in this case that could do it, but we know that that's negative. I don't know if I just seeing if that sparks anything in you. But I guess if we had time response to treatment in terms of laboratory values, right? Are all these things still climbing upwards, which still would make sense with shock, or have some things gotten better while other things have gotten worse? I'm not sure if maybe that would help here. But he obviously, it sounds like at this point, I mean, he's essentially just circling the drain, and we don't have the ability to get any more imaging. So I'm trying to come up with something that doesn't involve that. And I'm guessing the C. diff was negative, right? You sent the C. diff, all the things that were sent came back negative that were mentioned, correct? Okay. And then, right, like the mild pulmonary hypertension really is probably just the result of a little bit of that, whatever's going on in the lungs, right? I mean, it's probably just that, since we know that the LV is probably okay. And even if it isn't, that's not really what's causing all of this, I don't think. So I think I'm struggling with what to do next, particularly with the SWAN results, because I think that they really overall, the moral of the story is distributive shock, and also bad preload, bad return. I'm I don't know. I think I'd still give hydrocort and see how he responds to it. I think I'm drawing a little bit of a blank here. And I guess maybe the other thing here is where this is where you turn the patient, when the nurses turn the patient, you look at every ounce of their skin, right? Do they have any wounds anywhere? It sounds like this was a very short hospitalization before this, but I remember a patient who had a very similar presentation. It was distributive. We didn't know why. And then they had this huge sacral wound, gas throughout it. They actually ended up passing away, but there was a period of time where they got a little bit better on clindamycin. They actually ended up growing, Clostridium in their blood. Yes, so I guess that would be the other thing. But he was home. I don't know that there's any wounds anywhere, and so it's almost sort of like something has to be hiding if it's a source control issue, and if it's not, then I don't know. We're missing some other cause of distributive shock.
Yeah, I guess we always have the probe mic. I'm not very savvy with my POCUS skills, but since they can't go to the scanner, we could always scan the belly for hemorrhage that way.
We could do like a sort of fast exam, make sure that he's not, bleeding into some area in his abdomen. And I guess, again, like the repeat labs to see if that hemoglobin is now 6, right? That would definitely change the way we think about him. But yeah, I don't know yes, I guess we could take a look at the belly. We could get an abdominal x-ray if they can sneak it under there and see if there's free air or something. But I don't know.
But
Is he responsive at all at this point neurologically, to the point where like you can press on his belly and decide, see if he's grimacing or not? I imagine no, with 4 pressors on.
Well, Mike, I will say I thought the Legionella thought was really interesting, just because anyone comes in with a very prominent GI syndrome, infiltrates, they're very, very sick. I mean, that fits to a degree. Do these Legionella patients arrest because of shock though? I thought it was more like very refractory hypoxemia from just like widespread pulmonary devastation. I could be wrong, so I'm not opposed to escalating for like resistant Legionella treatment. But yeah, that's an interesting thought. Yeah, Brendan, what's next?
Aliquot 5 is going to reveal that all cultures so far have been negative to date. He is now on a 4th vasopressor, and epinephrine was added. So at this point, he's on levofed, vasopressin, phenylephrine, and epinephrine. He was too unstable for a CT of the abdomen pelvis. Zosyn was changed to meropenem given his recent hospitalization and concern for potentially a ESBL-producing organism. He had a repeat BMP obtained, which showed a sodium of 130, a potassium of 3.3, a chloride of 100, a bicarb of 16, BUN of 24, a creatinine of 1.4, and he had a glucose of 40. Urine sodium was obtained, which was 56. Urine osmolality was 388. He had repeat liver function testing, which revealed an AST of 400, an ALT of 290, total bilirubin of 2.0, with an indirect of 1.6. C. diff toxin was negative. He did have a right upper quadrant ultrasound with Doppler, which was also negative. He had a repeat CBC to check for declining hemoglobin or hematocrit, and that did reveal a white count of 12.0, a hemoglobin of 10.1 with a hematocrit of 30, and a platelet count of 44. He had repeat coags, which were normal, as well as a normal fibrinogen. He had an LDH of 303 and a normal haptoglobin, and that's going to be the end of Aliquot 5.
Okay, so I mean, at this point, I think this is something metabolic, Andrew. And these labs, now I'm realizing that the LFTs can climb far after everything else starts to get better. So I still don't know if that really helps me. His hemoglobin's come down 2 units, but who knows if that's, a little delusional with everything else, with all the fluids he's gotten, inflammation, sepsis, taking a lot of blood probably for various labs that we've all asked for. And so I think what I'm going to just quickly do here is, what's the anion gap for him? I want to see if that's, let's see, it's 100. Give me a second here. I don't have my MD calc here, so I've got to actually do it by hand. 14, right? So it's not, I was thinking maybe there's some sort of toxin on board. Um, I don't know. I'm gonna pass it to you, Andrew, not because of anything strong and wise, but because I'm drawing blanks here still. What are your thoughts?
No, I mean, I'd be calling for help here. I'm just wondering, Brendan, what was the heart rate through all of this? Got it. Okay. I asked that just because Mike is raising toxidromes, and if this person's on a beta blocker and they randomly decided that they wanted to overdose after the procedure, then that would be kind of signal that could be going on. But it sounds like that's not the case because we're not seeing that in the heart rate there. So no, I feel like I'm just, I mean, in a clinical reasoning exercise, we usually have time to hear how these results pan out. So what I was going to say is I'm waiting to hear kind of how the blood cultures grew, how the urine grew, what the kidneys eventually look like on the CT. Was this all pyelo and we just couldn't get them to the scanner and they got super, super sick from urosepsis? But in real life, this is like a very, very hard case. And I'm very rusty with my intensive medicine. So I'd certainly be asking for their help in real life and very excited to learn before I pass the mic.
Was he was there a lot of pain when he went home? Was he taking just tons of Tylenol? No. Okay. Um just thinking about other things that would, I mean, really the LFT should be in the thousands. Um does he have a strong drinking history? Okay, gotcha. I saw one guy who came in with actually a relatively similar presentation, and he actually was drinking turpentine. But he had a big gap. This guy doesn't have that. Yeah, I mean, I guess I'm sorry I keep harping on it because I think it's because I just don't have anything else. But, a random cortisol here, if it was 1, that would be helpful. If it was, 15, I don't know that it's terribly helpful, but I guess maybe that's what I would send in the absence of having already started steroids. But again, I think I'm anchoring, or at least continue to go back to that, not because I think that's what it is, but because I'm feeling uncomfortable and I'm clearly something is not clicking in terms of illness script here. And I think the thing that's most scary about this case is I don't know what to reach for next. And Andrew's mentioning calling for help, but other than calling for the ICU, I don't know, which consultant to talk to. And I'm interested to hear if you had any thoughts behind that thought, Andrew. But I think what's scary here is not just that I don't know what's going on, but additionally that I don't know what test to order next to get an answer. And I'm, again, just sort of being totally honest here, and I wanted to hear your thoughts.
Stumped. Brendan, I'm humbled. Teach us.
Peripheral smear was obtained, which revealed no platelet clumping with a few scattered schistocytes, less than 5 per high-powered field. He did have a positive platelet factor 4 assay as well as a positive confirmatory serotonin release assay. He went on to have a random cortisol checked, which was less than 2, as well as a markedly elevated ACTH level. Hydrocortisone was added at stress dosing as well as associated fludrocortisone, and within the next 4 hours he was weaned off all vasoactive support. He was given an additional 2 liters of IV crystalloid as well. He had a CT abdomen pelvis after he stabilized hemodynamically, which revealed enlargement and hemorrhage into the bilateral adrenal glands with bilateral overflowing thrombus into the IVC. Anticoagulation was started for presumed heparin-induced thrombocytopenia with argatroban, and the final diagnosis is acute adrenal insufficiency due to bilateral adrenal venous thrombosis resulting in adrenal hemorrhage in the bilateral adrenal glands.
Well played, Mike. That's a golf clap for Mike. Mike got it in the middle there. There we go, Mike. You saved his life. God, what a case.
Oh man, that's crazy. Yeah, that is what a case. And I guess, right, what I need to update or remember is that I basically think of HIT causing shock through a PE, but yeah, it infarcted the adrenals. And so that's such an interesting, I feel like that's my mechanism for HIT causing shock. And this is a new, totally different way that syndrome can do this. Wow. I'll say that, physiologically, I used to know this much better, and now it's just something I say to the residents, but I don't have a lot behind what I'm saying. You do need cortisol for any pressor to work. It's just, that's how it works. It works through a process that kind of is, and we can maybe put this on the website once I actually go back and read a textbook for once, but it works through a pathway that cortisol is involved in. And so you can't, pressors just do not work without cortisol on board. Fascinating. And I guess it was the heparin exposure at the prior hospitalization that did this all. And he developed this at home. Any thoughts, Andrew? Well, I guess any thoughts you have in general, Andrew, but I guess I was wondering specifically, is there a way that you guys are tying or did they ever tie sort of his, nausea, vomiting, diarrhea to his hit? Is there an easy way that I'm just kind of blanking on? What are your thoughts?
I think he was just suffering adrenal insufficiency symptoms, it sounds like, leading up to this before he kind of collapsed, because that's the script, like nausea, vomiting, orthostasis, remember, and then he just like fell off a cliff. And that's he had the stress of the recent surgery, but it took some time, it sounds like, for the adrenal glands to infarct. And the mechanism for adrenal infarction from a blood clot's very interesting. Some case reports describe the blood flow out of the adrenal gland as a vascular dam. And if you get venous infarction at this very exquisite site, basically you get so much back pressure on the adrenals that it just infarcts from this venous outflow obstruction, and it looks hemorrhagic. And that can fool you if this, because Mike, I was telling you about a case like this earlier this year. When you see it on the CT scan, everyone sees hemorrhage and they don't think clot; they think it's just bleeding. But it's the clot that's driving the bleeding in these cases. And if this case is you could have got into it a little bit differently if they didn't come in and shock again, if you got the imaging first. This was very kind of hard to solve in reverse, because if you see the case as, okay, this is adrenal infarction with blood clot, then you just pull up your ultra hypercoagulability DDX and boom, the platelets were 50 and they just had heparin 5 to 7 days ago from the cabbage, from the procedure. So that would have been another pathway to this, but this was very, very hard to solve the other way around. And I'm so glad that Brendan presented it.
Now for some teaching points in this associated case, which was very informative for me. As we all are aware, the adrenal gland is divided into two sections, the adrenal cortex as well as the adrenal medulla. The adrenal medulla is associated with the catecholamine and catecholamine production, such as norepinephrine and epinephrine. The cortex is responsible for stress hormones as well as adrenal androgens. That's divided up into cortisol, aldosterone, and again, the adrenal androgens in the cortex. Adrenal insufficiency really comes in three different flavors, and just like along with a lot of the HPA axis, this can be divided into primary, secondary, and tertiary disorders. Primary disorders are associated with adrenal pathology itself, whereas secondary disorders are associated with decreased ACTH production due to pituitary disease, and tertiary disorders are due to reduction in corticotropin-releasing hormone, secondary to hypothalamic disease. Tertiary and secondary disease usually are marked by preserved mineralocorticoid activity, which is regulated by the renin-angiotensin-aldosterone system. Primary disorders, because this is disruptive of the adrenal cortex and aldosterone is synthesized in the adrenal cortex, usually primary disease is associated with lack of mineralocorticoid activity as well as lack of cortisol production. The most common cause of primary adrenal insufficiency would be autoimmune adrenalitis, typically what we think of as being Addison's disease. This can be marked by a positive 21 alpha hydroxylase antibody in about 90% of patients. Other associated causes can be cancer-associated metastases, TB or fungal disease, infiltrative disease of the adrenal cortex or medulla, syphilis, hemorrhage. In these types of circumstances, you would think about disseminated intravascular coagulation, or DIC, HIT, as well as bleeding diatheses. Famously, a question is that etomidate can cause acute suppression and adrenal insufficiency. And as mentioned earlier, infiltrative disease can cause primary disease. When thinking about secondary disease, you want to think about postoperative changes involving the HPA axis, traumatic brain injury, or panhypopituitarism. And then tertiary disease, the most common cause there would be exogenous steroids, typically going to be greater than or equal to 10 milligrams of prednisone over a 3-week period or greater. In terms of testing for adrenal insufficiency, this is really divided up into whether the patient is acutely ill and inpatient, or whether the patient is relatively or mildly ill as an outpatient. In terms of outpatient testing, you usually would screen for adrenal insufficiency with a morning cortisol. Your threshold there is greater than 15 or less than 15, and your confirmatory test is going to be a ACTH stimulation test to confirm lack of rise of cortisol levels in a patient. In terms of inpatient workup, you would usually perform a cortisol stimulation test, which is going to be a 250 microgram test. And your threshold there is usually going to be greater than or equal to 18. You can also do an 8 a.m. Morning cortisol as well, though usually a stimulation test is going to be preferred in the inpatient setting just due to multiple factors going on and other derangements, potentially in the HPA axis. You're going to be checking for a cortisol level in the stimulation test after about 1 hour of giving the ACTH injection. This was a really informative case for me, and I have never seen a diagnosis of primary adrenal insufficiency arising from adrenal disease in itself, other than autoimmune adrenalitis. So to see a case where adrenal hemorrhage was caused by another disease entirely, which in this case was heparin-induced thrombocytopenia, it was thought that the patient had heparin exposure during his last hospitalization for a cabbage, and actually went home with the diagnosis of heparin-induced thrombocytopenia that worsened, leading to bilateral adrenal vein thrombosis, and then that thrombosis through back pressure caused adrenal hemorrhage. And we did see this on the CAT scan where he had overflowing thrombus into the IVC. When we went back and looked at his platelet counts in his prior hospitalization, they were declining prior to his discharge, and had kind of nadered when he presented to us in his shock-like state.
Brendan had a poker face the whole time, just so everyone knows. There's no indication that was where we were going.
Yeah, do not bet against Brendan, because he did not let on in the slightest. But Brendan, that was a fantastic case. I can't think of a more diagnostic atypia case than that. I mean, not an uncommon thing, adrenal insufficiency, but what an uncommon presentation of that. And again, just a reminder that patients can come to the hospital, even those who have just been here for something else and something major, and have a problem that maybe is sort of peripherally related, but not the same thing. I 100% would have said that this is cardiogenic shock when he arrived. That I think that I would have, until he came out of the cath, I probably would have just shut my brain off. I'll be totally honest, right? Like, just get him to cardiology. So really humbling, as Andrew said. Thank you for the fantastic teaching. Endocrine is for me always the most challenging subject, and so those are good reminders, and honestly a lot of novel teaching for me as well. So thank you.
Thank you for the opportunity today to present this case to you. I just really love and enjoy Diagnostic Atypia. I think you all are doing great work here, and I look forward to hearing more cases coming forth from you all and your educational endeavors. Thank you so much.
Thank you, Brendan.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us at dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.